happy to be here. And today I want to address the question, does embracing the neurodiversity paradigm entails rejecting the pharmacological treatment of ADHD? My answer will be no. And I'll argue that existing discussions of the neurodiversity paradigm don't do enough to dissipate this impression that the neurodiversity paradigm implies that we should not treat neurodivergent conditions, and in particular ADHD, pharmacologically. And I will show that this raises problems that shouldn't be underestimated. Unless we clearly show that there isn't such a tension, there's serious harm in shunning, interfering with medication. So the aim of this talk is to do precisely this, show that there isn't such a tension. And I will argue that the impression that there is this tension comes from a principle that has nothing to do with the tenets of the neurodiversity paradigm, but is external to it. And it has to do with assumptions about the relationship between treatment and disorders and what we should treat. And I will call this the define to justly treat principle. Then I will propose a different approach for deciding when a treatment is legitimate based on cost-benefit assessment. And I will finally consider and reject another argument that grants this cost-benefit approach, but still rejects ADHD medications. So here was the plan. The term neurodiversity refers to a variety of cognition styles and neurological profiles found across the population. And the concept was coined in the late 90s by the autistic sociologist Judy Singer and by the journalist Harvey Bloom independently, and was emerging from the online community of autistic people who argued for the recognition of autism as a form of cognitive difference rather than a deficit. And it was part of a rejection to the rise of eugenics-inspired genetic research programs to cure or prevent autism, and widespread use of ABA, applied behaviors analysis, for autistic children, which many experienced as traumatic and abusive, and an attempt to suppress autistic traits rather than support autistic people. So this term is modeled on biodiversity, and it suggests a normative commitment. Just as biodiversity is valuable and worth preserving, so too is neurodiversity, a variety to be cultivated rather than eliminated. People often talk of the neurodiversity paradigm then to refer to this framework of understanding certain conditions as non-pathological variations in normal functioning that are statistically less prevalent rather than disorders. And these conditions are typically neurodevelopmental conditions such as autism, ADHD, dyslexia, dyspraxia, dysgraphia, dyscalculia, and Tourette syndrome. The neurodiversity paradigm frames itself in explicit opposition to what its proponent call the pathology paradigm or the disorder paradigm, the dominant biomedical framework that understands conditions like ADHD or autism as disorders to be treated. And Nick Walker articulates these very starkly. They claim the two paradigms, the pathology paradigm and the neurodiversity paradigm, are as fundamentally incompatible as, say, homophobia and the gay rights movement, or misogyny and feminism. In terms of discourse, research, and policy, the pathology paradigm asks, what do we do about the problem of these people not being normal? Whereas the neurodiversity paradigm asked, what do we do about the problem of these people being oppressed, marginalized, and or poorly served, poorly accommodated by the prevailing culture? This is a stark contrast there. What is this pathology paradigm Walker is talking about? There is no consensus on what counts as a medical disorder, but prevailing mental disorder, but prevailing accounts which inform the DSM-5 and much of the clinical practice and approach conceive of mental disorders as involving some kind of dysfunction, where dysfunction is conceived as a value-free biological notion. However, the pathology model is broader than that. For instance, recently there's a resurgence of skill-based accounts of mental disorders where mental disorders are seen as deficits in some form of appropriate responsiveness to reasons, or in deficits in the skilled metacognitive self-regulation required for rational interpretability. So in both cases, it's some deficit in the subject skills that have to do with rationality. And these views differ greatly from the disorder, dysfunction view of disorder, but they have something in common, which I think captures the core of the pathology paradigm. It is the idea that the harm and the disablement is caused by something wrong or defective with the subject, some internal defect with the person. On the other hand, the neurodiversity model is grounded in the social model of disability. On this view, the harm and the reduction in flourishing, the disablement experienced by neurodivergent people is not primarily caused by a dysfunction or a deficit. It is caused by social structures, practices, and environments designed to benefit those with the most prevalent neurotypes, and that puts neurodivergent people as a disadvantage. And the biases, the stigma, the discrimination that are related to this. And this means that helping neurodivergent people doesn't require medical intervention, but political and social justice interventions. And the Chapman claims neurodiversity advocates take the classification to indicate a marginalized minority rather than a medical condition, making it more in line with political identities such as trans or gay than something that we should attempt to treat or cure. And in a paper together with Bovel, Chapman again claims that treatment is deeply unethical and based on a catastrophically misguided undue pathologization of a minority way of being. And many proponents have argued that treatment of neurodivergence is akin to gay conversion therapy. It aims to treat something that's not pathological and equally unethical. So in these claims, there seems to be an implicit but not so implicit argument. I will formulate the argument as an argument about the treatment of ADHD, even though the discussion on the neurodiversity paradigm and its relation to treatment is not usually put with a focus on ADHD. But I think we have a lot to learn if we pay attention to ADHD rather than autism when we are thinking about treatment. For many reasons, one of which is that there is a first-line medical treatment of ADHD, which is very well supported by evidence, and that a lot of people find extremely useful. So it's interesting to see what's going on there, rather than thinking at the theoretical possibility of treating autism, for which there isn't currently an established treatment. ADHD is, so the argument goes as follows. ADHD is a neurodivergent condition. Neurodivergent conditions are normal variations in cognitive style and are not pathologies or deficits. Pharmacological treatment is permissible only when there is a disorder to fix. And the conclusion of this argument is that pharmacological treatment is not permissible for ADHD. And clearly, the crucial premise that we need to question is 3. But before doing that, we need to look at what has been said about treatment by proponents of the neurodiversity paradigm. The most careful and sophisticated neurodiversity scholar I'm aware of is Robert Chapman. So a lot of the arguments I look at are from them. And here are some things they say. So some proponents of the neurodiversity model see the danger of a blanket rejection of treatment. They recognize that some neurodivergent people find medical treatment helpful, and they are critical of med-shaming attitudes that have become common in some areas of the neurodiversity movement. And Chapman, for instance, claims that autistic people may indeed need medical treatment. Again, contrary to what I'm doing, Chapman focuses on autism and not on ADHD. So they claim that autistic people may indeed need medical treatment, but what gets treated there is some co-occurring condition, not the autism itself. This argument doesn't help us if what we want is making space for ADHD treatment, because what gets addressed with psychostimulant medications is not some co-occurring conditions, but executive function challenges that are part of the profile of ADHD. Another argument is making a distinction between psychotherapy that is seen as admissible because its goal is not to change the way the brain works or the cognitive style of the person, but it is to have the person coping with the challenges that arise from navigating an unsupportive environment. So that's permissible versus biomedical interventions whose goal is to alter the neurological functioning. And again, that doesn't help with ADHD because there is an alteration of the neurological functioning. So why is it important to disentangle the neurodiversity paradigm from the rejection of the pharmacological treatment? Because I think it produces a lot of harm along several dimensions. First of all, it steers away people from medications that can be life-altering and sometimes life-saving, both by inducing people to believe that it's incompatible with what they believe to take medication, so they will not take medication, and both by risking reducing resources and funding in allowing people to access medication with services that are already very much overstretched and unable to serve a lot of the population that need it. And this is quite important. There are the first line treatment for ADHD, psychostimulants, taken by millions of people globally, is among of the most effective and best evidence pharmacological treatment in psychiatry. And we know that adults with untreated ADHD are significantly more likely to be unemployed, and not in education, incarcerated, addicted to substances, to develop comorbidities, to die prematurely, have higher rates of suicide. And we know that stimulant medication have been shown to significantly reduce those negative outcomes. Another less visible harm is epistemic, and in particular, hermeneutical injustice. So hermeneutical injustice is a well-known concept developed by Miranda Fricker, and it occurs when a gap in the collective interpretative resources puts a person at an unfair disadvantage of making sense of understanding their own experience. And the pathology paradigm has long left neurodivergent people in this situation of hermeneutical injustice, not making sense of their experience. And the neurodiversity paradigm has been introduced as a way of reducing this hermeneutical injustice and offering this much needed interpretative tool. It offers conceptual resources that allow neurodivergent people to understand themselves as different rather than defective, and has made it possible to develop a lot of concepts that are very important to the self-understanding of the neurodivergent communities, particularly autistic people, with the development of conceptual tools such as masking, neurodivergent burnout, the double empathy problem, the idea of differences in communication styles and what these differences are about, internalized ableism. So this is a positive aspect in terms of reducing hermeneutical injustice of the neurodiversity paradigm. But unless we decouple the neurodiversity paradigm from this alleged incompatibility with medication, it trades one hermeneutical injustice for another. The ADHDer will find the neurodiversity paradigm useful for the self-understanding, but does find medication useful, finds himself in this situation where none of the framework make their own experience intelligible. And this causes a lot of existential anguish, self-identity question, confusion, because the neurodiversity paradigms treats the desire and need for medication as a betrayal of their full identity, while they experience their use of medication very often as enabling them to actualize their full identity. Another form of harm is harm to autonomy. So consider a lawyer with ADHD. Her executive function challenges make it difficult to meet court deadline, track document, manage the caseload, and she overcompensated by working long hours. She ends up with sleep deprivation, chronic anxiety, guilt, and ends up developing physical problems. But law is her call. It's really related of what she cares about most. It makes her feel fulfilled and engaged. And it might even be that some of her ADHD traits are precisely what makes her so attractive attracted to this job. The high stakes, the high pressure of the job, the fast pace that's exciting, the possibility to dive into hyper-focus when she's working and preparing cases, the performance aspect of the court work, her need for this high sense of justice that's related to working for the justice system. And the ADHD medications for this person that we're thinking about enable her to practice in a sustainable way and pursue the career that makes her feel fulfilled. And she could make changes in her life, like changing career, that would make her need for medications disappear. If she became a gardener, she might not need medication, but she would also have to abandon a life project that is very fulfilling for her and very attached to her sense of self. So there's a limiting of the scope of autonomy and self-efficacy for the individual. And finally, the widespread idea that neurodiversity paradigm is incompatible with treatment slows down the acceptance of the neurodiversity paradigm among clinicians and researchers that might be more skeptical, that they need to be in embracing the paradigm and developing clinical approaches and research projects that are in line with it. So, fortunately, all these forms of harm can be avoided because I would argue there isn't a good reason to see the neurodiversity paradigm as in tension with the legitimacy of ADHD medications. So let's have a look again at this argument that I presented before and the crucial premise that I think is problematic. And it's problematic because it's not true that we deem pharmacological treatment as permissible only in the presence of a disorder. In medicine, medications are often prescribed to treat things that are not considered disorders. They're prescribed for pain, even if pain is arguably not a disorder, but a functional response. Anti-contraceptive pills are prescribed, even if fertility is not a disorder. And on the other hand, even infertility is not considered by most a disorder, and fertility treatment is provided. And anesthetics are used, even if consciousness and alertness are not a disorder. But while pharmacological treating non-pathological conditions is well established in medicine, there is a strong acceptance of something along the line of premise 3 in philosophy of psychiatry. And this is for some reasons that are motivated by the darker history of psychiatry. So psychiatry has long used psychiatric categories from hysteria, drapetomania, to pathologizing homosexuality, to oppress differences, repress dissent, enforce compliance. And in response to this, psychiatry has sought to define more rigorously the borders of its scope to avoid the arbitrary and weaponized pathologization of social groups that are deemed problematic by the current society. So in response to this, something along the line of these principles has become widely accepted. I call this define to justly treat principle. And it says that we can avoid undue treatment only if we have necessary and sufficient conditions for what counts as a medical disorder. And we only treat what fulfills those conditions. So treatment is legitimate only when it is something to do with something being internally wrong that defines with necessary and sufficient conditions what can be, what is a disorder. And many proponents of the neurodiversity framework seems to accept this principle as well. Chapman, again, for instance, argues that some conditions are genuine disorders and should be treated, while others are not. And they claim that a condition counts as a disorder if it extinguishes the possibility of flourishing under any possible society. So a different characterization of these necessary and sufficient conditions that most people in the traditional philosophy of psychiatry pathology camp, but nonetheless these kind of conditions. And their example is anencephaly versus autism that does not extinguish the possibility of flourishing under all possible conditions, societies, and therefore is not a disorder. The problem with the define to justly treat principle is that every attempt at defining a disorder systematically runs into problems and counterexamples, and no consensus has been reached. And instead, many are proposing practical and pluralistic accounts of disorder, as they're noticing more and more that all these attempts are failing, and there is no unique encompassing definition that works for all contexts. We can only have concepts of disorders that are context and perspective dependent. If this is true, this would mean that the define to justly treat principle is wishful thinking. But then, if this is the case, how do we decide if a psychiatric treatment is just or legitimate? I propose to switch from a definitional approach, defining what mental disorders are in order to establish what is appropriate to treat, to a cost-benefit assessment approach. Something similar has been proposed by Kukla in the paper, What Counts as Disease and Why Does It Matter? There are differences that are not particularly relevant right now, and I don't have time to go into. And the idea is that the treatment is legitimate when the benefits of medicating outweigh the risks. And this is messier and more complex than the define to justly treat principle. It doesn't give us a clear-cut one-size-fits-all recipe, and it can't be decided once and for all. It needs to take into account the historical, contingent, changeable facts about the medical treatments, what medical treatments are available, the effectiveness, the side effects, and the risk factor of each individual, the stigma surrounding medication at a time, the stigma surrounding behavioral traits associated with the conditions at any time, social circumstances of the individual for whom we are considering medications. But in all its messiness, it reflects more closely the actual practice of clinical psychiatry, which, as it happens, already has to make judgments across multiple dimensions. The considering the probability and magnitude of the benefits and harms, the availability and comparative effectiveness of alternative interventions, the patient's values and preferences and needs, the reversibility of the interventions, the quality of the consent, and broader social context. And So all these are obviously value-laden judgment. And I think this is a big advantage of the risk-benefit approach, because it doesn't allow psychiatry to hide behind the purported certainty of naturalism and dodge important fine-tuned ethical questions and case-by-case considerations, and requires psychiatry to make its value commitment explicit, to recognize that decisions about what counts as appropriate treatment are never purely factual, are never purely based on natural facts, but always about assumptions about flourishing, about good life, about the proper relationship between the individual and the social environment. And making these commitments explicit enables clinicians and researchers to make more careful, to attend more carefully to the patient's needs and values, question implicit neuronormative assumptions, consider their goals and desire in treatment plan. And this is exactly what the neurodiversity paradigm advocates for. One might accept this and still argue that it's precisely the cost-benefit assessment that tells us that ADHD medications are illegitimate, because the cost of them outweighed the benefit. Among the risks, there are not only the medication side effects, not only the medication side effects on the individual, but also social side effects. For instance, the availability of ADHD medication risks steering away our collective attention from structural and political changes that would make society more inclusive and would make people with ADHD not need medications to function in that society. Things like changes in how education, work, and society at large are structured, and what skills and what traits are valued and praiseworthy in our society. So the cost of legitimizing medications is to delay what would be a more effective and more just treatment with long-lasting benefits for ADHDers. So one might come up with the following argument, and this is really the last slide. If the harm and disablement related to a condition are caused by social factors, social interventions are the most appropriate and just intervention and should be preferred to medical treatment whenever possible. In ADHD, the harm is indeed caused by social factors. Social and ecological interventions that reduce the harm to ADHDers are possible. Pharmacological treatment of ADHD risk delaying social and ecological intervention. Conclusions: we shouldn't medicate people with ADHD. Now, we might question premise 4. It is true that reliance on ADHD medication risks legitimizing the idea that these changes are not urgent or so important. But I think that what really legitimizes this idea is the belief that if something is treated medically and pharmacologically, it means that it must be a disorder. And so it's that assumption, the defined to justly treat assumption, that we should challenge. But more importantly, this argument relies a lot on what we mean by possible in both premise 1 and 3. So if it means possible in principle in a future possible world, then 3 is true, but it's not clear that we should prefer social interventions over medical treatment. So it means, it would mean to say that interventions that are not accessible now should, it would mean to say that because there are interventions that are in principle possible, but not available now, we should leave people with ADHD unmedicated and without support. And on the other hand, if we mean possible as currently available, it would mean that certain interventions are indeed possible and accessible right now to some people, but not to others. To some people, changing jobs, changing the school setting, going to forest school would be resolutive of their disablement and impediment to flourishing. But to some people don't, and this risks fostering inequalities. And so, to conclude very briefly, this is now to say that we shouldn't work toward a more inclusive society. We absolutely should, but working towards that society doesn't preclude right now the legitimacy of medical treatment for ADHD. And this is all. Thank you.